I just wanted to start a little bit about talking about kind of, this word addiction. I'm still titled as an addiction medicine specialist, although it's not a word that we use as much these days. The ICD criteria tend to talk about things as substance use disorders, but it's kind of, I guess, in common parlance, still used a fair bit. Um, and there's still lots of different thoughts about what it is. So, yeah, you're probably all pretty familiar with the criteria that it's using alcohol or other substances on a regular basis, typically daily, with a prioritization of those things over other activities, the associated harms, and interference with various aspects of functioning that comes with that, and then obviously an inability to stop using those substances or to change that particular behavior. And I guess there's lots of kind of misconceptions around this as well. So this kind of belief that it's someone's fault, that somehow they've got less willpower than others, or they're less principled, or that people are just kind of hooked on a high, and that's too important for them. And these things are all very big misconceptions and really miss what substance use disorder is. And especially, I mean, this notion of people getting a high, that might happen very early on when people use various things, but typically prolonged use is more about avoiding withdrawal rather than anything else. And there is this kind of complex milieu of life events that can lead to someone getting to this point. And what I say to all my clients is that no one develops a substance use disorder for no reason. There's always things that sit behind it. There's probably some biological component. There's a lot of talk about genetics and things. Those have all been widely debunked. That there are certainly some epigenetic things, but the biology is a very minimal part of it. Environmental factors, development exposure is really important, and life events. And I'm going to focus a little bit now on trauma and childhood adversity as the major contributor to substance use disorder. And I think if we aren't aware of that, if we don't ask about that, if we don't consider that in managing these people, we will never get very far. This is just such an important part of identifying what's going on for people and getting to the root causes of what's been going on for them. And if we don't do that, then we don't really do our job, and we aren't really able to support them. So this is a study done in the 90s by a chap called Vincent Felitti. Here's a obesity clinician in the States. And sorry, I think I can see bits and pieces in the chat, but I don't. Oh, there we go. Yeah, that's okay. All right. I'll just get my screen back up. Sorry. Yeah, so Felitti was an obesity clinician in the States, and he, within his clinical work, started to identify that patients presenting with morbid obesity seems to have a higher likelihood of having adverse events in childhood. And so he did some more research about that and found quite a strong correlation. And this piqued his curiosity, and he decided that it would be interesting to see the kind of longitudinal effects of childhood adversity across a whole range of domains. And so he did this thing called the ACE study. And so he used these questionnaires so these were people who were enrolling into a health insurance company. As you know, in the States, most people have healthcare through particular private health insurance. And so these are just de novo patients arriving to Kaiser Permanente, one of the health insurance groups. And so just a cross section of 13,500 adults. And he put together this questionnaire that covered this list of categories. And I think I've got a slide for that next. So these are the categories that he looked at in this particular study. So you can see their psychological abuse, which included things like being emotionally abused, put down, physical, sexual, and then dysfunction within the household. So things like substance abuse, family members who had mental illness or attempted suicide, how mum was treated at home, and criminal behaviour. Was anyone incarcerated from the home? And I think perhaps one of the most remarkable things about that is the total prevalence of these kind of things. So over half of those surveyed identified at least one of these things. And you can see, disturbingly, some pretty high results across some of those things, particularly things like substance abuse and sexual abuse. So that's pretty concerning just from a cross section of society. And so then what he looked at was, in terms of people that responded in the positive to any of these categories, um, and then looked at some of the longer term sequelae in life. So, for example, did the person consider themselves to have an alcohol problem? And so those that didn't answer yes to any of the categories, the prevalence was relatively low. Going right through to those that had 4 or more yeses across the categories, they had a 7.4 odds ratio. So huge increased risk of a self-reported alcohol problem. And this is repeated across lots of domains. So you can see there things like illicit drugs, so 28%. 28% of the people reported illicit drug use versus only 6% of those who had answered no to all of the categories. Injecting drug use as an odds adjusted ratio there, 10.3. Even things here like STIs, number of sexual partners, things like smoking, you can see there an increased risk, severe obesity, which is kind of where he started from. Even interesting things like no leisure time physical activity, so people not really prioritizing healthy activity and those kind of things. Depressed mood, huge increased risk of that. The suicide rate profoundly increased, 12.2 odds ratio. But even these interesting things too, and I'm not going to focus on this tonight, but it's a really interesting thing to see that ischemic heart disease, any form of cancer, stroke, bronchitis and emphysema, diabetes, things like that, things that would very typically be considered biomedical problems, and we would rarely consider. That's the list of the categories there that I mentioned before. And these are, as I said, some of these prevalence and odd ratios. And I think I was up to this slide here, and you're welcome to get a copy of the slides if you're interested. So you can see there, even things that are considered very biomedical type conditions were influenced by people's experiences in childhood. So this notion that anything is purely biomedical, I think, is naive and something that we need to be aware of, and particularly in the area of substance use that we're going to talk about tonight. And Felici did this little follow-up study here, which I think is quite interestingly titled "Turning Gold into Lead." And this particular chart, I think, here is really compelling. You can see there that that a male child with a score of 6 or more, so answering yes to most categories, there's a 4,600% increased risk in the likelihood of later using IV drugs. So these kind of negative experiences in childhood have a hugely profound effect on people. And so I think to think of these people as people chasing a high or junkies are all kind of terms that are thrown around, apart from being extremely pejorative, really misses the point about what has got people to where they are. And it's a very simplistic view. So this is really important to consider when we're seeing these kind of people. And I think it helps us to have a lot of compassion for people, and helps us to recognize that this hasn't happened by accident. So I'm a GP by background, and I'm still signed up to the GP News thing. So I sometimes get these things, and I was interested to see kind of around this time last year this article come out that childhood maltreatment is linked to 40% of mental health conditions, and it staggers me to think that Felici's research was done in the 90s, and 25 odd years later, we're putting this stuff out like this is some kind of new thing that we've never realized before. It's great to see that it's being acknowledged, but it's quite surprising to see that it's really taken such a long time to be mainstream, and I still don't think it really is. So with all that in mind, so this is a little infographic from the Alcohol and Drug Foundation website. It's a really useful website if you're interested, if you're seeing a patient that mentions something unusual or even something common and you're not really sure. They tell you they're using GHB and you're not really sure what that is and how that works. They have some great information on the ADF website, and some simple stuff about kind of what to expect in overdose and withdrawal and things like that. So if you want a kind of quick cheat sheet on things, it's really helpful and really useful. And as you can see, there's a huge range of different substances that people use. but there are some more prevalent than others. So tonight I'm just going to focus on alcohol, amphetamines, and opioids. But obviously there's lots of other stuff as well. Um, and again, you can find more information out about those kind of things, and I'll give you some other resources to get support should you need that if you come across any of these other things as well. Um, so this is some data from the Australian Institute of Health and Wellbeing. It's a couple of years old now, but looking at presentations to hospital by drug category. So you can see there, alcohol overwhelmingly dominates this. And in terms of harm, money spent, everything, alcohol dominates all of this. So it is the number one problem. The bulk of the reason people come to our inpatient detox unit. And in terms of kind of societal impact, it's far and above. The reason I circled the methamphetamine one there is that methamphetamine tends to buy a lot more airtime, particularly in news media and things like that. And there's not small numbers associated with that, but you can see that alcohol just kind of dwarfs anything else really. Cannabis probably has the highest amount of use in terms of illicit substance, but it doesn't tend to necessitate the kind of size of hospital admissions and things. Although you can see there with the cannabinoids, it's not nothing either. Whereas opioids relatively are smallish in terms of number of hospital admissions, but in terms of overall harm and mortality and things, it's pretty significant. Um, so alcohol, is a very interesting one in Australian society. It's got a pretty firm and rooted place in terms of who we are and how we operate. You can see there that kind of any politician worth his salt goes down to the pub and downs a beer, and the sports teams. It's a pretty important part of that as well, even if you're drinking out of a shoe, which is pretty gross. But it's a really kind of dyed in the sand part of Australian culture. So often that line between what's a reasonable amount of consumption and what's not is really blurry for the general population. And there's kind of been this long-held notion of functional alcoholics, and people that can drink every day, but I can get up and do my job, so I'm fine. And so there's lots that's kind of tricky to unpack, and so kind of being direct with people and asking about their alcohol consumption is really important. Um, so in terms of alcohol use, I don't know if you've all seen the kind of latest NHMRC guidelines. So there used to be guidelines around about number of alcohol-free days and drinks per day and things like that, and it's kind of been simplified a bit now. So it's just no more than 10 standard drinks a week and no more than 4 drinks on any given day. And you'll see there that the less you drink, the lower your risk of harm. So an acknowledgement that no alcohol is ideal, but less than 10 a week it keeps you in a pretty safe range. And you can see there what's interesting is that, and this is again data here from the Australian Institute of Health and Welfare, that people, either abstainers or people that used to drink and now don't, that the total proportion has actually gone up, and there's almost a quarter of Australians. So that's a pretty significant number. Matched up against the kind of those who have a risky lifetime risk of alcohol, that's also fallen as well. So less people drinking regularly and more people abstaining and less people kind of drinking on a risky pattern. And even the single occasional risk, so that more kind of binge pattern, there's been some fall in that as well. So that all looks really positive, and certainly we know in the younger cohort, the kind of Gen Z, like under 20s and even into their early 20s, the rate of alcohol consumption has fallen quite considerably, and no one quite understands what that's about. And lots of people want to take credit for it, but the alcohol consumption amongst that population has really reduced. But that's kind of married up against this. I'll come back to that one in a moment. This stat here, where you can see that overall total alcohol consumption's continued to increase quite aggressively, despite the fact you can see a fall there in beer, but an increase in wine and spirits kind of plodding along. And so I'll let you have a think about the reason for that for a second while you see these. Alan and Roger, who their idea of a standard drink was different to other people. So when you're quizzing people about how many drinks, kind of tease out what a standard drink is, how much they're actually drinking is important, because people have different ideas of what that looks like. So this really what this is showing us is that whilst there are more people not drinking and a reduction in risky drinking, things like that, there are a cohort of heavy drinkers who continue to drink more and more heavily. And that is the cohort that really is at substantial risk. And so whilst there's been some inroads in other parts of the population, there's this very high risk group where really we haven't done so well. Um, in terms of risk of drinking, smoking, things like that, and illicit use, you can see here that that risk is more significant for those for people essentially as you move out of the urban areas and out into more regional areas. So those who are very remote have the highest risk of drinking and smoking. Um, and there's lots of reasons for that, but certainly something to be aware of, particularly for those of you who are working in those areas, and making sure you're having discussions with people about this and giving them opportunities to identify problems that they might be having. And there's lots of initiatives and things that have been going on to try and address this and provide support for people in regional areas. Equally, Indigenous Australians. So interestingly, the proportion of Indigenous Australians who identify drinking at risky levels is actually smaller than non-Indigenous Australians. But you can see there that what's this proportion there? Uh, Sorry, I haven't looked at these slides for the while. And essentially, there are a large number of abstainers amongst the Indigenous population, but for those who drink, they tend to drink at much more risky levels, essentially. So, again, really important questions to ask if you've got patients who are Indigenous Australians and trying to ascertain what their drink is like and if there's risk associated with it, again, so that you can connect them to support and provide support for them. Um, so, um, this is a little, I'm not sure exactly how we do this, but I guess I'll give you a few minutes and then people can make comments as they want to. But so this is Anne. She's a 50-year-old lady who presents to your GP clinic. So she's been drinking 2 bottles of wine per day the last 6 months, and she's kind of come and volunteered that herself because she's been pulled over by the cops and she blew 0.2 when she got pulled over, lost her license on the spot, really embarrassed about it. No history of seizures, alcohol withdrawal or otherwise, and otherwise pretty healthy. She's got 2 grown-up daughters. They don't live with her, but they're supportive. She's depressed and anxious and she wants to stop. So she's really aware. She's been aware there's been a problem, but this driving thing has really alerted her to the fact that there's a problem here that she needs to get on top of. So, a couple of things to think about. So, is Anne going to withdraw? Is that going to be a problem you need to think about? If you think she is, what are you going to do about that? How are you going to manage that withdrawal? And what do you do? How do you manage a withdrawal? So you've got someone in your practice there, they've been drinking 2 bottles of wine daily. What are you going to do for them? So if anyone's brave or willing to put forward some suggestions, go for it. Anyone want to share any thoughts? Otherwise, I can keep talking, but then you have to put up with me. Anything in the chat? Let's have a look. Um, yep. So we can do. Yeah. So look, I think Karen, that's a really good response. That sometimes the kind of knee-jerk response is to detox people, but you don't necessarily have to do that. So you could come up with a reduction plan, and I think that's really reasonable. And if that's something that that Anne is keen on, rather than a kind of abrupt stop, that would be a perfectly reasonable approach as well, and just really gradual reductions, and sometimes getting people to kind of measure wine out into, yeah, tip it out into jugs and things like that, and then measuring that can be a reasonable way to do it. Not everyone can manage that, but for those that can, it's a pretty reasonable approach. Um, yeah, and I think, Kevin, you're right. A community detox. Um, Sometimes there's this, again, a knee-jerk thing. They've got to go. They've got to have an inpatient detox. We've got to admit them somewhere to do that, and sometimes that's true. But also, community detox is a really reasonable approach. Well, good evidence base for them, cost effective, so reasonable to think about as well. Um, in terms of some of the questions here is around the monitoring and things and safety. So yeah, she's obviously not got a history of seizures. Is there anything else you might worry about in terms of if she wanted to do a detox and you wanted to choose between doing it as an inpatient or an outpatient, is there anything else that might push you one way or another in terms of which pathway you're going to consider? Yeah, sure. Yep. Yep. So she's got to have support. There's got to be someone there who can keep an eye on her in case things start going pear-shaped. Absolutely. Motivation would be a most likely positive approach. Yeah. So I think, there's that kind of motivation piece is interesting, Tanya, with people, and that can flip back and forth a little bit. At the moment, it seems like she's in this sweet spot where motivation is significant, having had this driving incident, things like that. So certainly being able to provide support in real time while that motivation is there and driving her. And certainly we know that loss of license is a really considerable motivator. Some studies would suggest that it's more motivating than being incarcerated. So it's a really powerful motivator for people. So, yeah, I think we definitely want to capitalize on that while that's feeling strong for her. So, yeah, so what are we going to do? Yeah, this hopefully is going to work for me. Great. So in terms of risk of withdrawal, so is she at risk of withdrawal? Yes. And so these are the things we kind of look at in terms of withdrawal. So for men, more than 80 grams of alcohol a day, women more than 60 grams. So a bottle of wine, give or take, is 70. So she's about 140 grams a day. So she comfortably meets that criteria. And we assume she's had a drink within the last 10 days. So you can use the CAGE questionnaire to kind of find out. But really, I guess it's about, she's drinking alcohol every day for the last 6 months. So I'm pretty confident she's going to score pretty high on the CAGE criteria. The history of previous alcohol withdrawal. So what's happened if they've tried to stop before? Sometimes patients really haven't, and so they won't have that history, but often people have. They've run out of money, they've gone on a holiday, something like that. So what happened before? So obviously things like seizures you're particularly concerned about, but even other severe withdrawals, that may not necessarily mean that you won't offer them an outpatient detox, although in the case of seizures, particularly if it's in recent, you probably wouldn't. But if there's other significant withdrawal features, you could potentially still do an outpatient withdrawal with good supports if they had a really sensible support person, but you also might decide to do an inpatient withdrawal, which is fine. Yeah, and if their blood alcohol concentration is significant, then obviously they're at risk for withdrawal as well. So in terms of alcohol withdrawals, so this is a bit of a chart of kind of what happens in terms of the negative effects of withdrawal. So really that kind of period, that risk of seizure is really the first 48 hours, as you can see from that graph there. But it's not entirely kind of eliminated at 48 hours. There is this potential risk afterwards. That's not very common. If you manage the withdrawal well early, it's very unlikely to have a seizure beyond that point. But there are people with vulnerable brains where that can be a little bit more likely to occur. In terms of these other things like the nausea, tremor, sweats, anxiety, disturbed sleep, hypertension, tachycardia, look, those are relatively common. But again, the better you manage the withdrawal early, the less likely you are to have these as significant problems. If you don't manage the withdrawal well early, then again, these things become far more problematic for people. And that's when a poorly managed withdrawal, you can see here, it's more like day 3, 4, 5, where things like a true delirium tremens can come in. And lots of people get confused about a delirium tremens, but it's more than just shaky hands. That's pretty normal. So it's an acutely agitated, confused state, and they are relatively rare. And again, they're really only seen if that early part of the withdrawal is not managed, or someone doesn't present, or if they're really underdosed on medication or whatever, to support them through that early part of the withdrawal. So again, hit them hard early, make sure you get on top of the symptoms, and then wing that down fairly quickly, and you can support them through most withdrawals pretty well. So the aims here, I mean, obviously trying to make it a little bit more comfortable for people, but particularly to prevent those really significant potential complications. And mostly they can be avoided really easily, again, with appropriate management. But really, I think those two red dot points are really, really important. And ideally, before you even commence the withdrawal. Now, sometimes, you'll see people in such a position, they've come into hospital or whatever, that they're already in withdrawal, and so you've got to manage that. But as I think it was Karen mentioned earlier, if you had someone like this who was happy to keep drinking for a little while you put some other plans in place for her, that might be even better. Because really the worst thing is that you get someone through a withdrawal and they don't really have any aftercare to go on with. Nothing else has changed for them, and it's pretty hard not to just go back to those pre-existing patterns. So I think working together to come up with a really effective and appropriate treatment plan, even getting them to engage with supports, meet counsellors, do all those kind of things, even while they're still actively drinking, so that when you do make that time to stop, that those supports are ready to go and back them up, and they can really link into that really well. And again, we'll talk a little bit more about some potential options for people in a moment. Concerns of oversedation and overdose. Look, again, if people are drinking really significantly, it's very unlikely you're going to overdose them on benzos, unless maybe you're doing a home-based detox and they start drinking again while they're taking the benzos, which is again why you need a sensible support person if that's the pathway you're going. Underdosing and alcohol withdrawal escalation. So yeah, generally, there's pretty good pathways and things that we'll talk about in a minute. But there are sometimes people that will just withdraw a lot harder. And again, if they've got that history of really significant withdrawal, you've got some heads up around that. But there is sometimes times when people will need extra benzo to get them through that withdrawal. And again, looking at those objective signs of withdrawal, so things like the tachycardias and the raised blood pressures and things like that show you that it's more a feature of a nasty withdrawal rather than just overwhelming anxiety, which is very common in alcohol withdrawal as well. And obviously ruling out other problems that might be going on for people at the same time as a withdrawal. So outpatient or community withdrawals are really, really appropriate. And again, it's going to depend a little bit on you guys and how comfortable and confident you are to kind of do those. So again, the things that might make you think twice about that is certainly a recent seizure history or significant history of seizure. You probably then don't want to engage with that. If they've got, like we mentioned, severe withdrawals in the past, and again, particularly if in recent history, if they've got really significant comorbidities and things where an inpatient setting is going to be more helpful, then obviously bringing them into an inpatient environment would be better. Again, if they don't have those good social supports, if they've got severe and active psychiatric comorbidities, and if there's polysubstance use, so there's multiple things they're going to be withdrawing from at once, it's going to make it a bit more of a rough withdrawal. Then you might want to do that in a supported environment so you can respond appropriately to the withdrawal symptoms. Look, I think the person at home is really, really important. If it was a really low level that someone was drinking and you really were kind of umming and ahhing whether they're going to have withdrawal or not at all, well, then maybe a home visiting service would be fine. But anyone who's drinking a decent amount, I'm not sure that's really going to be enough. I think you really want someone with the person to be able to support them and identify where things might be going wrong. So daily visits are ideal, or if they can bring the person to you, that's fine as well. So diazepam is gold standard We'll talk about the regime in a moment. If you're even contemplating using something like lorazepam because of deranged liver function tests and things like that, then yeah, I wouldn't recommend doing that in the community. I'd do that in an inpatient setting. So diazepam should be fine for all community withdrawals. Thiamine, so being aware that when people are drinking regularly, they really don't absorb thiamine orally at all. If there's any signs of Wernicke's, so any of those typical kind of confusion, eye signs, disturbed gait, things like that, then you probably need to admit them and give them parenteral thiamine. But if there's none of that, then start them on some oral thiamine. And ideally, if they're able to continue to abstain, then get them to take some thiamine afterwards as well. It's not a common problem, but it's pretty cheap and pretty safe thing to do for people, so worthwhile doing. And having backup plans. So if things go pear-shaped, what do you do? Have you got a hospital backup or DASA withdrawal services or something like that that you can call back on if you need to? And again, ahead of time if possible, or at the very least an ongoing discussion around what other supports are going to come in for people. How is this person going to continue to address this issue that the detox is really just the tip of the iceberg for? CWAR scores, if you're not familiar with those, they're easy to find. This is the list of them here. Um, so the CWAR is a well-validated tool, but again, it's still subjective. So patients who've done them more will know the go pretty easy. The other thing is that with that subjectivity, as I said, a lot of people, those kind of underlying anxieties and things can really rise up when alcohol's no longer there to kind of quell that. So it's kind of picking out what's a significant concerning withdrawal and what's more an emergence of that anxiety. And that's where those more objective markers, things like blood pressure and pulse rate and things like that are useful to look at as well. So kind of reading those two things together and getting a picture of where the patient's at rather than just going on the CWAR. And also looking at the general trend of CWAR. So, if someone scores a CWAR of 13 and then you give them 20 milligrams of diazepam and then it's still 13, you give them 20 more and it's still 13, what's going on? Is this a really terrible withdrawal, or are these scores not perhaps conveying actually what's going on? So keeping a kind of a trend of that as well is really important. So as I mentioned, benzos are the gold standard. They are effective in terms of relieving symptoms, but they also reduce the chance of seizures and things like that, particularly in terms of diazepam. So they work on GABA, obviously, same as alcohol. Alcohol acts on a number of receptors, but it's typically GABA that drives that seizure issue. So the benzos are good to reduce the chance of that. Diazepam's got that nice long-acting profile, which is great. They're cheap, easy available. In terms of the disadvantages, so yes, they are sedating. People can have a fall and things like that. People can potentially obviously develop dependence on benzodiazepines. And I think it's really important in terms of how we pitch that to people when we are doing a detox, because there is an essence of where we don't want you to drink, so we're going to give you these medications instead. But then, there can be this implicit message that your alcohol problem isn't great, but benzos are fine. And in some ways, it's just a substitution. So it's about talking people through that as well and explaining what the rationale is for that, that it's keeping them safe through this withdrawal period, but it's not a long-term thing, and that the long-term thing is going to be to support them in other ways, particularly like counselling support and those kind of things. So there's different ways to do it. There's the symptom triggered more CWAR. And again, if it's a community-based withdrawal, you're probably not going to do that. You're probably going to work more off of a fixed schedule. And if you go onto the DASA website, that's got plenty of information about that there if you're ever contemplating one. Lorazepam, as I said, if you're looking at even thinking about lorazepam, then probably they need to be in an inpatient setting because they've got liver function that's significantly deranged. That really an inpatient setting is going to be better to monitor that and monitor their response to withdrawal. So I'm pretty sure this is still the fixed schedule that's on the DASA website, but some variation of this is fine. So Typically, our protocol is 40 milligrams for the first 2 days, and then dropping back by 10 milligrams a day. Some actually drops by 15 on day 3, but probably 40, 40, 30, 20, 10, something like that. So some kind of derivation of this is fine. And again, preparing patients for that, explaining that that's how it's going to run, and explaining that that really matches the risk. So that first 48 hours is the high risk period, and after that, the risk reduces. So therefore, you can safely wean those down. And so, giving patients a clear heads up, that's what's going to happen, so they're prepared and ready for it. So thiamine we've already talked about. So definitely if they're low weight, malnourished, if they've got any signs of Wernicke's or they've got liver disease, then you probably want to give them parenteral thiamine, in which case they'll need to be in an inpatient facility. Otherwise, orally, we tend to give it for a month, really, for most people, just as a standard thing, or at least suggest it for a month. In terms of kind of replacing multivitamins, things like magnesium, phosphate, can all be deranged potassium to a degree. Again, if these are relatively well people in an outpatient setting, you probably don't need to worry too much about this stuff. But if they're unwell in an inpatient setting, these are definitely things you should be having a look at and making sure that there's no problem and you don't need to replace those. Sorry, I got a note here from Kevin. Is there a different approach for detoxing alcohol patients who are prescribed longer-term benzos? Yes. So I guess two things. So one is, do they want to do anything about their benzos at this stage? Is that something they want to change, or do they want to keep going with them? So if they wanted to wean their benzos as well, then you probably need to give them a bit more benzo initially, and then you together work out a longer term tapering plan for those. If they don't really want to change their benzos, and that's not the hill you want to die on at this point of time, then you'd kind of add this diazepam volume on top of what they're taking, and then wean them back down to their kind of baseline level, and then continue to have those chats to them about ongoing role of benzos and that kind of stuff. And look, bearing in mind with those fixed pace regimens, again, part of what we're looking for is having those contingency plans as well. So if the withdrawal isn't going like we expected, if the symptoms are more significant, and we're starting to get worried that this isn't a well-controlled withdrawal, having those clear plans about what we do about that. Where do we send this patient? How do we get support? How do we get someone else to have a look at them? Those are important kind of contingency things to have in place, particularly for an outpatient-based withdrawal. Symptomatic medications, sometimes people get a bit of the runs, although they may well have diarrhea and things if they're drinking regularly anyway. Nausea is relatively common, so maybe having an option for managing that for them, a bit of Maxilon or something, and simple analgesia if there's some aches and pains. Those are probably the key things, although again, mostly the diazepam manages most things for most people. All right. So, so in terms of longer term treatment and support, and obviously this is really the key. So, as I mentioned right at the start, in terms of the adverse childhood stuff, trauma, things like that, look, it's obviously a really important thing, but I'm also really aware and acknowledge that getting access to support for that for trauma-based therapy and things is really challenging, really expensive, not particularly available. So it's a huge problem, basically. And so looking for options where you can get some support around that, if those exist, is great. There are things like STARS. So for people who've been refugees or come from overseas, maybe some specific trauma support for those kind of people. But it's really challenging to find the support. You can do mental health care plans, but even then, often the financial impost to access psychology and counselling is really significant for people, and they find it hard to sustain. So I don't have great answers to that, but I guess just continuing to try and support that patient as best you can. Otherwise, in terms of more alcohol-specific stuff, so there's the kind of support groups, things like AA, which obviously has a very specific model and way of working, which tends to be pretty polarizing. People either really connect with it or really dislike it. And so working out where your patient's at and what side of the fence they kind of sit on. I think it is important to note that AA looks very different in different places. There's different groups, there's single gendered groups, there's groups of older people, younger people, all kinds of stuff. And so it is worthwhile if people even slightly feel drawn to the Alcoholics Anonymous model to try a few different groups and see if there's something that really sits with them. If they don't click with the AA idea, but they like the idea of a group support, then Smart Recovery is another really good one. It's more based on a CBT style model. But again, get that kind of camaraderie and community, which is really important for people too. Um, so there's plenty of one-on-one stuff as well. We'll talk a little bit more about that later on. Um, Ongoing connection with you as a GP is really, really important, and having a GP that is non-judgmental, that's happy to ask them and talk to them about their alcohol, is happy to deal with the ebbs and flows that happens with people experiencing alcohol use disorder, who can sit with them and guide them through that is really important too. And if they get to the point where they're really keen and they're open to something like a residential rehab, then that's a really great option for people getting that really long-term break from alcohol, as well as really intensive work on kind of changing habits and patterns and things. So there's again, I'll talk about some of those options later on as well. But yeah, the key thing is just to be there, to be consistent, and to keep supporting your patient. And if you can do that, there really are people that do really, really well, and it's really rewarding to see that. For
Sorry to
families,
interrupt. Michael, there are two people who have
yeah.
raised their hands. Maybe they want to talk. Do you want me to
Oh,
allow
okay.
them?
Sorry, I can't see the raised hands, so that's
Yeah, so
fine.
Thomas, I have allowed you to talk if you want to ask something.
I think actually mine was putting an answer into the Q&A rather than the chat by
Ah,
mistake.
okay,
Yeah,
all
it
good.
wasn't a question, it was more a
Okay,
statement.
let me check with Karen. Karen, do you want to ask something? Hello, Karen. Okay, maybe you can type it in chat function if that's all right. All good.
Yeah, and there's another looks like a question somewhere here, which isn't in the chat, but somewhere else about gambling addiction. So, and I think that was in reference to the kind of childhood adversity stuff that I was mentioning. Um, Look, I think absolutely. I think that that childhood adversity, there's lots of different ways that people can seek to cope with those experiences, and gambling certainly can be one thing. Sometimes people kind of look really healthy. People go out and they become workaholics and they, overachievers and things like that, and that's their way of coping with what they've experienced as well. So it can look lots of different ways, but I think that's one of the important things for us as clinicians, isn't it, to understand our patients and to ask them about things like that. And I think it's something we rarely do, is to ask people, what was your childhood like, and to get a better understanding of that so that we can understand them better as people, and then hopefully support them better too. Um, so families, so being connected to someone who's got a substance use disorder can be really stressful, really emotionally draining, really overwhelming. Um, so I think support for families is really, really important. So there's the family drug support, which is a confidential and free support line. There are also meetings connected to that as well. And I believe there's also some like Zoom style meetings that people in rural areas can access as well. So a really good resource if you've got partners, children, friends of people who are struggling with these kind of things. Um, this I'll put. I think I've got this up a couple of times tonight, but really important, and I'm sure most of you are familiar with this anyway. So DASA, we offer it used to be 24 hour, but I think it's 8:30 till 10:30, 8 in the morning to 10:30, 10 o'clock at night. Confidential telephone counselling service. So people can call this free of charge. They can get over the phone advice. support. They can get information about support services. They can book themselves in to come and see DASA, either as an inpatient or an outpatient. So it's a one-stop shop. And there's lovely people on that phone line who are really happy to chat to people, take some time and find out what's going on for them. So that's certainly a really useful number to give out to patients that might be struggling with this, or even family members that have people who are struggling, so that maybe when that motivation does strike, they've got somewhere that they can link in and get some support. So feel free to share that number with people. This is not for patients, so please don't give this number out, but this is our specialist support lines. It's a 24-hour line. Myself and my colleagues man this to provide advice around clinical issues. So if you've got someone that's doing an outpatient detox or something similar, and some of the other substances we're going to talk about in a minute, or something that we haven't talked about tonight, and you want some support around those things, then that number is available. It's as someone who answers this line, I'm probably going to be slightly better at supporting if you call me during the daytime. But if there's something urgent at night, we will take calls and support you as well. So jot that one down, and always happy to take calls, or you can flick us an email as well, whatever's most helpful. All right. What are we up to? Yeah. Okay. Do people need a 2-minute break to grab a drink or something? We're kind of halfway through. Yeah.
I think should be fine.
Should we find to have a break, or we continue on?
Yeah, I think we'll just break for 5 minutes and then we can come back.
Okay, sounds good. All right. So we're ready to keep going.
Yes, I think we should start.
Yeah, that's fine. Sorry, I was just getting my screen back up, and you can see my screen still.
Yes, I can. Yep.
Great. All right. So that was a really quick tour of alcohol. Definitely happy to take more questions at the end. Just before I jump into the amphetamine stuff, Kevin's put a question in the chat about video gaming and social media addiction as a recognized thing. Certainly, there's a growing understanding of gaming addiction. There's one of my colleagues, Dr. Michael Bajan, does a lot in this area. Um, uh, and again, kind of similar things. It does tend to be a younger cohort of people more so, and certainly some significant crossover with gaming and gambling. And a lot of the gaming stuff is there's a lot of kind of overtures around gambling as well, and really interesting stuff. It's not a core part of my work, and certainly not something I would be able to speak knowledgeably on. But there's some really interesting stuff out there, and there is a gambling unit down at Flinders Hospital run by Michael Bajan, and they do a bit of gaming stuff as well. So there is support available for people if you've got patients with those kind of concerns. All right. So methamphetamine, as we mentioned, it's another uh, pretty significant thing out there in the community and talked about a lot. And it does make media a lot. And there's often various throwaway lines in the advertising and other things about Adelaide being the methamphetamine capital of Australia and things like that. Um, so what is it? Well, it's a stimulant. It comes in various forms. Typically, the ice or the crystal meth is what's available now. It can be smoked or injected. That's mostly what people will do, but some people take it orally or also rectally as well. People mostly will refer to their use in points, which refers to 0.1 of a gram. Um, again, the purity of what's around varies wildly. So it's very hard to know kind of overall how much people are using, but it's a bit of a rough guide in terms of points. Anything kind of up to half a gram, so 5 points is on the lower end. Anything above that starts to get pretty significant use, and typically those who smoke methamphetamine will use more than those who inject. Um, and yes, it's less commonly used than what you would think from the media. I hope this is going to change for me. Right. Sorry. Let's get this thing going again. I thought we'd solved this issue. All right. Great. So you can see, and you guys can see that. That's all okay. Hopefully it's
Yes,
clicking
all
through.
good. Yeah, we can see
Yeah,
it.
great. Excellent. So again, some data here from the Australian Institute of Health and Welfare. So you can see there in terms of methamphetamine use, quite significant reductions actually from the early 2000s down to 2019. Now, we'll be honest that in COVID, the methamphetamine use fell quite significantly because it was very difficult for people to transport it and move it around. It's certainly rebounded up since then, and some of the recent wastewater sampling suggested in Adelaide that it's rising back up again. So it's a little bit fluctuant, but it's certainly, those really high levels are not something that we're seeing at the moment. So what does it do? So it's a stimulant. So, people feel euphoric, increased energy, they stay awake. They also get an increased heart rate. And they can also have these, drug-induced psychoses and things are far more common with amphetamines. Weight loss, sometimes in the past, amphetamine or low dose stimulants have been used for weight loss stuff. So this is Russell. So Russell's is a 23-year-old chap who works fly in, fly out up at the mines. So he goes away for a couple of weeks and then home for a week at a time. So he smokes methamphetamine, doesn't inject it, and he only uses it for a few days when he's home because he's aware that he's got to pass a urine drug screen at work from time to time. Doesn't use it when he's away at the mines. Um, so he drinks a six-pack of rum and coke, so about 90 grams of alcohol a day on the same days. And when he stops using and is looking to head back up to the mine, he struggles to sleep and he gets pretty agitated and edgy as well. Um, so, what's is Russell going to get much in the way of methamphetamine withdrawal or not? What about alcohol? What else do you want to know? Do you think medications are going to be helpful for him? What features are concerning? What features are reassuring? And what help could you offer for him? So feel free to throw some things in the chat about what you might think if you saw Russell. Any thoughts about him? Yeah, I think that's really fair, Kevin. So getting an idea of what he's actually doing in the mines, like is he driving a massive truck? um, and are there any concerns around that? Is he legit about how much he's using and how much he's not? Is he having those long breaks or not? Was he drinking while covered the mines? Karen suggested doing some motivational interviewing and handing him over to Dasa. Both are fine. Thomas suggested, yes, he's withdrawing from both already. Yep, and I think that's clear, isn't it? That it's mentioning some withdrawal symptoms. So much as he's not using daily, he's using kind of in this on-off pattern. It's consistent enough that there's some kind of neuroplasticity going on there, isn't it? And what's gone on for him at home and up in the mines, like when he's up there, how safe is he in terms of withdrawals and things as well? So a lower level alcohol use is probably going to be okay, but he's probably going to feel pretty yuck. So in terms of withdrawal management, this is more looking at the amphetamine side of things. But so amphetamine withdrawals are not life-threatening. They don't need to be admitted for methamphetamine withdrawals. Are very much safe to manage in an outpatient environment. Mostly people have that intense fatigue, so what's called a meth crash when they stop using. So they sleep a lot um, and generally don't want to have much to do with anyone for a couple of days, and then they kind of wake back up again. And at that point, they can be much more agitated and irritable. And that ongoing sleep disturbance is pretty common. In terms of the other thing with the longer term is that so there's acute withdrawals in methamphetamine are probably the most significant, but people tend to get what we call latent withdrawals or persistent withdrawals, however you want to term it, and essentially that that people have flooded their brains with dopamine, have this massive increase of dopamine receptors, and then suddenly they've got nothing kind of hitting any of those receptors, and so they feel really flat, really down, really unhappy. Often they struggle with motivation and things, and that takes quite a long time for them to adjust to that. And so I think preparing people for that is really important and helping them to understand that a week isn't going to change much, that it's going to be a much longer term thing. And that's where I think that that drug-free environment is really important. So if you withdraw someone from amphetamines and then they go back into the same environment where the dealer lives next door and it's freely available to them and other people in the household are using, it's incredibly hard for people to sustain long-term abstinence in that kind of setting. So, those are really important considerations in terms of looking what you do for people. And Kevin's asked about tazepine. I'll chat about that in a second. Whoops. So, yeah, I think it's really reasonable to have a think about a sudden detox versus a gradual reduction in use. So I've had a number of patients who've done really, really well, just slowly making changes to their methamphetamine use with a clear goal that they wanted to stop, but they just knew that a kind of an abrupt change wasn't going to work for them, and looking to minimise harm. So sometimes you end up having slightly unusual conversations with people, like encouraging them to smoke only and avoid injected use, and then maybe trying to change from that to oral use. So gradually kind of reducing harm, whilst also making reductions in use, can be a really appropriate way to manage people too. Or if people really want to do a detox and go that way, it's fine to support them in that as well. And as mentioned, an outpatient environment is really reasonable. But thinking again about what comes next for people, if nothing changes, the chance of success is going to be pretty low. So what can you do to support them around some of that social stuff as well? Yes. So in medications for methamphetamine management, and Kevin was asking about etazapine, it's a real evidence grey zone. So there is no solid evidence for any medication in methamphetamine management. We tend to use, and certainly myself, I tend to use a little bit of low dose olanzapine to support some of that agitation. Again, there's no really great evidence base for that. Some people will use some pericyanine. Some people use benzos. I'm perhaps a little bit more cautious with benzos myself, but it's not inappropriate to think about that. But there's no good evidence around any of this. So it's really about working with the patient in front of you, kind of working out what are the key things for them and what's going to help them the best. Mirtazapine's sometimes been helpful for people maybe more from that sleep effect. So people that are really struggling to reset their diurnal rhythm, maybe a little bit of mirtazapine at night to kind of support that. But again, pretty low dose generally. And again, short term mostly, maybe a couple of weeks, 3 weeks, something like that. And for these other medications, diazepam and olanzapine, generally just 10 days. So just short term use to kind of reset things. And again, with a really clear conversation with the patient that they're not going to feel brilliant at the end of that time. They'll feel better, but it's going to take longer than that for things to really settle, and preparing them well for that and being there to support them as they work through that. So long-term management. So again, no really clear evidence around what the best option is. There's been lots of different medications trialed. There was recently some results published around something called the Lisdex trial, which is looking at, the Lima trial, which is looking at Lisdex amphetamine as almost like a substitute. And that seemed to show some positive effect for 3 or 4 weeks and nothing beyond that. There's another couple of trials looking at more at mirtazapine again. There's been a look at modafinil, and you probably might have heard various people being prescribed modafinil, so a low-dose stimulant, for management, a longer-term management of methamphetamine withdrawal. And again, the evidence base around that doesn't tend to suggest it's any better than placebo, although maybe there's some benefit because people have to come and see you to get a script, and so they kind of remain linked in with care, and that maybe in itself is somewhat protective. So Stephen's commented the biggest problem with managing patients with substance use disorder is managing their sleep. Any tips? Totally agree. And I think that's multifaceted. So their sleep is pretty disturbed from their alcohol, amphetamine, whatever else they've been using. So that's one problem. So they've just got poor sleep hygiene. But the second thing is, again, people generally using this stuff for a reason, and a lot of it is to kind of drown out, to overwhelm, to numb those difficult memories, thoughts, past experiences, things like that. And with nothing there, those things tend to really surface and bubble up and be really difficult to cope with. Typical of all of those kind of things, that they tend to then affect people's capacity to get to sleep and to stay asleep. People have nightmares, all kinds of things. So there's kind of those two things going on. So look, I think, again, expectation setting for clients, explaining that sleep disturbance is not unusual, that it's something they're going to have to work on. I think good support around sleep hygiene, sleep patterns, like setting times they go to bed and get up, trying to get them to do things during the day that use up some of their energy, not just sitting watching TV or whatever. that avoiding other replacement things, coffee, other kind of stimulants like that. So some of that really basic stuff, but just trying to, again, expectation set to help people to know what's normal and what's not. Because if people feel it's really unusual, they tend to fixate on it more. And then obviously trying to support people around some of that anxiety, the other side of things, the difficult thoughts, dark memories, things that can come up, and trying your best to kind of support them around some of that stuff as well. And so kind of trying to do those two things together. Clonidine be useful for sleep issues. Look, there's various medications that people try. I must admit, I tend to try to avoid that. And my main reason for that is that I guess what I was saying before about the benzodiazepines is that potentially if we're telling people, it's not great to drink alcohol, so instead replace that with these benzos, it kind of reinforces that notion for people that the way to deal with these difficult things is to take medication, and medication is universally not very effective for managing these things. So it's not that you can't use those things, but I think it's really important how you message that, and how you explain what the purpose is for people. Otherwise, it can just quickly become pretty a replacement thing. And as we know, that although medication can sometimes help with sleep initiation, generally pharmacotherapy tends to lead to less good quality of sleep. People don't get that nice restorative sleep, and so it's not really providing the benefit that we want in terms of mood and energy and those kind of things. So it's not that you can't do that, but again, I think caution in terms of how you're doing that, expectation setting, how long are you going to use them for, those kind of things as well. So there's no really clear evidence of pharmacological stuff in the long-term management of methamphetamine. Again, sometimes things are used. So things like mirtazapine sometimes gets used. As I said, sometimes modafinil can be used for people who are really struggling with somnolence, to try and help with a little bit of get up and go. But again, generally for limited periods of time, with and clearly monitoring the effect of that. So there's a study done called the MATES cohort trial back about a decade ago in New South Wales and Queensland that looked at resi rehab and inpatient detox. So there was some suggestion that resi rehab was somewhat helpful, but no evidence that inpatient detox was beneficial for people. So sometimes that's seen as the be-all and end-all, and for some patients it still might be helpful. But again, if it's done in isolation and nothing else changes, it's very unlikely to provide much benefit for people. And again, I think from my perspective, the focus is, what's been going on for this person? Why is this a part of their life? What's happened? And how do we build a rapport with this person so that we can start to then support them to look at some of these root causes, and maybe if they can't necessarily change those things, how do they cope with those when that distress rises up and feels overwhelming? What can we build in their toolkit to be able to better manage that stuff? All right, so that there's a pretty quick coverage of methamphetamine, but as I said, it's generally pretty safe in terms of withdrawal. Is this a long haul with methamphetamine? It's difficult to support people to change that. It's pretty entrenched in certain segments of society, so it can be really, really hard. So wherever there's possibility to support people around the more social issues that accompany it, that's really important. So we'll finish up with opioids tonight. And as you can see from the images there, really the emphasis of my talk is more on prescribed or pharmaceutical opioids, because that is more what we see here in South Australia. So I'm not sure if any of you look at the annual Pennington Institute overdose report, but opioids continue to lead the way each year in that. And you can see there that they make up a substantial proportion of the 2,000 or over 2,000 deaths in Australia. There's a little bit of lag time with these reports, so this is the latest one at the moment. In terms of drug types, so you can see there opioids, benzos, and stimulants certainly increasing in terms of their contribution. But what's interesting here is that opioids, it's very unusual for them alone to cause problems. You can see there the grey line, pharmaceutical opioids only, is right down the bottom, and heroin is just above it. It's when it's used in combination with other things, and benzos are pretty significant. And the other pharmaceuticals there includes things like gabapentinoids, Lyrica, and things like that, which are again, there's been an increasing awareness of their contribution to polysubstance overdose. So just exercising caution when you've got patients on those combination medications. Again, this is just kind of showing that here in South Australia, heroin really, even in Australia, overall, that you can see that orange line in the late 90s, early 2000s really drops off a cliff and then remains very low for heroin. In the eastern states, there's still more of it. But here in South Australia, it's not nearly as significant as these other things. So you can see there the natural and semi-synthetic, so oxycodone, morphine, things like that. And then the synthetic line in the blue, which is the fentanyl, tramadol, the massive increase in tapentadol. I'll talk about that in a moment, and that's probably changed these figures slightly since 2021. So you can see there, so this is some of the data from DASA from the wastewater in South Australia, and you can see there this kind of continuous reduction in opioids in the wastewater from kind of this peak in 2014, 2015. So our opioid kind of crisis, if you will, was nothing like the one in the States, but there was a period where the levels got much higher, and that's really come down quite nicely, which is excellent. As I said, props and compared to heroin here, you can see that the levels have been low for a long time and haven't really increased significantly. And the average levels from 2021 for the lowest since sampling began. So you can see there that it's really dropped right down in South Australia. So what you can see here from the National Household Drug Survey, so asking people about their opioid use, you can see a fall in oxycodone from a high level and a fall in codeine from a relatively high level. And I don't know why they chose all these different shades of green for this thing. It's really unhelpful, but you can see a green line there surging up from the bottom, and that's tapentadol. I think I'll come back to that in a moment because I've got another note about that. This is again from the National Drug Household Survey. You can see that in terms of prescription opioids, more common amongst older females and females in general. And that again, more likely in those who are living further away from regional centres. This is a study that just came out in the last week or two, which I thought was interesting. So this was looking at opioid prescribing rates in Victoria. And so looking particularly in primary care, general practice over a 5-year period. So initiation of opioids fell across most age groups, just like we saw from some of that data. Although interestingly, and I'd say suggest quite concerningly, there was a significant increase of 69% in the 15 to 24-year-old category. So that's somewhat worrying, and not really sure what would kind of necessitate such a huge increase in that age group. Interestingly, as I've mentioned a few times, the tapentadol prescriptions rose by 263%. So there's a huge increase in tapentadol prescribing, and that certainly mirrors what I'm seeing in my clinic with a significant increase in referrals of people who are struggling with tapentadol misuse and dependence. And it's interesting because I think it's been largely sold that tapentadol is a safe opioid, it's a good opioid, it's an okay opioid. And interestingly, the PI, which I've quoted at the bottom here, doesn't at all suggest that it says Polexia contains opioid and is a potential drug of abuse, misuse, and addiction. Addiction can occur in patients appropriately prescribed Polexia at recommended doses, and that's certainly something that I'm seeing a lot of. And yeah, Kevin's just put a note there that he said lots of patients have been prescribed Polexia not even knowing that it was an opioid. And that's certainly something I've seen as well. And I think that the doses, people perhaps don't realise the oral morphine equivalent of the doses of Polexia either. So it's not uncommon to see people on kind of 400 milligrams or even 500 milligrams a day. And if you punch that into an opioid calculator, you can get a bit of a surprise by how significant oral morphine equivalent that is. So just something to be aware of. And it is very popular. It's prescribed a lot post-operatively, private hospitals as well. And so again, having those discussions with patients about weaning and ceasing that as soon as possible, and those kind of things. There we go. So again, just making that point in terms of looking at people living in cities versus moving out further into the regions. So again, heroin more common in the cities, but as soon as you get out into the regions, becomes very uncommon, and those prescribed or prescription-based opioids really take over and become far more common, particularly things like oxycodone. You can see there in the blue line. So this is another patient that's come to see you, Diane. So she's a 35-year-old single mum with 2 kids. She's got a history of chronic low back pain. So she doesn't really have a typical GP. She sees whoever's available. She's pitched up to see you today. Having looked through her record, so she's on Targen 2010 3 times a day. She takes some endone for breakthrough. She's got some diazepam for muscle spasms, temazepam for sleep. She's on sertraline, some pregabalin for her back pain, and she's also on quetiapine because she's still not sleeping that well. And her main presentation today is that she's getting these pain flares and she feels really uncomfortable, and she wants you to do something about that for her. So, with that in mind and that list there, what else do you want to know? Are you happy with this regime? Are there red flags? If not, what do you want to do? What are you going to do about the pain flares, which is her key concern? And what are you thinking about safety here? Is there anything you want to do about that? So again, feel free to throw some things in the chat. Kevin's very kindly offered to phone me. And yes, I'm very happy to see these kind of patients if they land in your lap. This is kind of my bread and butter. But yeah, there are other things you can do as well in the meantime. Encourage reg. Sorry, I'm not sure what that, as in, yeah, what does reg mean, Karen? Oh, yes. Yep. Encourage a single GP. Absolutely. Yep. Yeah. And clearly, this is a bit of a product of, just seeing people one off, and things get perpetuated and maintained and added to and whatnot without a consistent person being involved. Yeah. So, yeah, try to rationalize the opioids and the benzos for sure. So, just crack on because I'm aware of the time. So just a couple of quick things. So this is an article from Pains, this is the key journal of the International Society for Study of Pain. So and there's lots of articles like this. Is this one that I particularly like to quote. But looking at the efficacy and safety of what they describe as strong opioids for chronic non-cancer pain. This is a broad and sweeping systematic review, and I quite like it because it includes 500,000 patients, so it's a big patient population, and it's got long follow-up, 6 to 12 months, so a lot better than a lot of the others. It includes a range of opioids, including oxycodone and tapentadol. It also includes buprenorphine, which I generally do think of as separate, given that it's a partial agonist, but they have included it here in this review. So among the chronic non-cancer pain population, they found that the pain intensity and pain-related function favoured the non-opioid group. And there may be some bias in that people who had less pain and better function didn't feel they needed an opioid, but that is interesting that those people did tend to function better and feel their pain was better. And there was a clinically important improvement that favoured those that weren't given opioids. Unsurprisingly, the opioid abuse and dependence was associated with high doses of opioids. This is probably the most concerning thing in this study, is that they found 2 extra deaths per 1,000 in the opioid group, suggesting that opioids may increase all-cause mortality. That's really, really worrying. And again, just a strong kind of reminder that these drugs aren't benign or inert, but they really cause significant morbidity and mortality. So as much as we want to help patients, the jury's well and truly out that the opioids aren't the best way to do that. that long-term treatment is associated with more adverse effects. And interestingly here that they excluded patients with past substance abuse, severe comorbidities, and mental health disorders. So this was a particularly well population, and yet still those 2 extra deaths per 1,000. So that's really, really concerning in my opinion. So in the midst of all the kind of opioid crisis, about a decade ago, the CDC brought out these guidelines, and many of you are familiar with these, a kind of set of 12 statements that they had around prescribing opioids in the chronic pain context. So again, that kind of affirmation that non-pharmacological and non-opioid pharmacological treatments are more effective and less harmful. They kind of flagged what's now become this kind of gospel thing that generally sticking to doses below 50 milligrams oral morphine equivalent per day and avoiding doses greater than 90 or 100, depending on who you ask. That there was no evidence for a long-term benefit of opioids in pain and function versus non-opioids, and when they examined outcomes at least a year later, and that this one, which we kind of all know but often struggle to do, which is to be continually assessing the benefits versus harms, and then and making changes accordingly. These are the NICE guidelines from the UK that came out a bit later on, so 2021. So looking at chronic pain management in over 16s, and you can see there that essentially NICE has said there's no evidence to prescribe anything for chronic pain. No Panadol, no NSAIDs, no benzos, no nothing. And that's fine, but most of us are pragmatists and would suggest that not kind of offering the patient anything is going to be hard to build rapport. So I think things like paracetamol and non-steroidals can certainly still potentially have a place. But just, again, pointing out that there really isn't good evidence for a lot of this stuff that typically is done. This is the SA Health fact sheet around the risks associated with opioids. I'm not sure if any of you have read this. It's a 4-page document. I quite love the fact that SA Health decides to kick off that risk number 1 is death, and kind of go on from there. But there's a long list of things associated with long-term use of opioids. So there's the kind of more well-known stuff like the constipation and the dental issues, and the kind of the tolerance and dependence stuff. Perhaps some of the stuff that's less well known and less talked about is the endocrinopathies and things. So the immune suppression, the reduced glucose tolerance, things like osteoporosis, interference with menstrual cycle, and the kind of reduction in testosterone, which tends to lead to fatigue and lack of muscle build up and muscle wasting and things like that. So people become more lethargic, struggle to move, and then the less they move, the more they hurt. So it kind of has this downward spiral. The opioid-induced hyperalgesia, which most people these days are familiar with, that kind of opposite effect where people that take these longer term tend to become increasingly sensitive to pain, rather than the other way around. And look, the other thing around that, the dependent stuff, which I think is important to be aware of, is a lot of these medications, even those which are badged as long-acting, generally don't act nearly as long as they say. So, for example, things like Targin or slow-release Tapentadol, I reckon that they last more like 4 to 6 hours. So if people are taking them twice a day, they tend to experience multiple withdrawals day and night. And so often a lot of what people are presenting with and describing as pain flares are actually just withdrawal events. And so that's one of the really significant downsides of these medications. Kevin's asked a question about THC, and I'll certainly come to that in a moment for sure. This is a study, again, one of these pretty concerning studies from Canada. It's a prospective study, so a little bit more difficult to rig things, but a bunch of patients that presented to Montreal one of the hospitals in Montreal, and then those of the kind of 3,500 patients, those that filled at least one opioid script in the 90 days post-discharge were followed up for 12 months. These are both medical and surgical patients. So of those that filled a script, more than 3/4 of them got the script on discharge, and the oral morphine equivalent that they were discharged with was 35 milligrams a day. So pretty, like, it's in that lower risk level, but it's still a reasonable amount to be sent home with. Again, most of them were discharged on oxycodone, which is pretty typical of what happens here as well. And interestingly, in the 12 months following discharge, 16%, so a large cohort, had an opioid-related ED visit, hospitalisation, or died as a direct result of their opioids. So that's incredibly concerning. The risk was greater with those with prolonged continuous use and higher doses, unsurprisingly. And again, people that had known opioid dependency were excluded from this study. So these are people kind of de novo opioid users. So really concerning stuff. Script check. Hopefully you guys all know about that. The GPs tend to be mostly better with it than the hospital guys, but it is mandatory. You are expected to check it, and it is really, really helpful. So it shows you all the particular medications they target. So opioids, Schedule 8s, benzos, quetiapine, pregabalin. So it's really helpful to have a look at that. And it brings up these red flags here. The algorithm isn't always on point, but it'll look for things like people that have obtained drugs from different pharmacies, from different doctors. It'll look at combinations, and it'll look at oral morphine equivalents as well. So it's just a little helpful prompt for you to see what's been going on, especially if it's a patient that hasn't attended your practice before. So in terms of Diane, so we script checked for her. And so what she declared was about 135 milligrams of oral morphine daily. When we had a look at script check, it turned out that she'd actually not told us everything. So she was using more like 250 milligrams a day. So really significant risk associated with that. She'd also been getting extra scripts for benzos and pregabalin, so more like 40 milligrams a day of diazepam and 1.5 grams of Lyrica. And at this point, she conceded that she really needed some help with this medication problem that she'd developed. So again, I mentioned this briefly before, looking at the Pennington Institute report, but unsurprisingly, there's the increased risk associated with opioids combined with sedatives, and there's kind of different figures put around this, but certainly pretty significant increased risk. Again, the Pennington report and also data from NDRC, the National Drug and Alcohol Research Council, suggests that benzos are the most common drug involved in an opioid overdose. Although interestingly, there was some another study that was done for people on MATOD, so on opioid agonist treatment for sort of methadone, Suboxone, and looking at their safety in terms of co-ingestion of other sedatives, so benzos, other opioids, and gabapentinoids, and the risk ratio was most significant for the gabapentinoids. So again, the pregabalin, the gabapentin often kind of sneak under the radar. People feel like they're a little bit safer or a little less harmful. The data just doesn't seem to support that. That they, as well as benzos, all confer pretty significant risk in the context of opioids as well. So important to think about. And I've got a little bit about pregabalin here because it's not my favorite drug. So it's interesting, pregabalin. The kind of initial studies weren't that great. Numbers needed to treat 4 to 6, numbers needed to harm was only 10, so a pretty small gap between the two. In other countries, it got various kind of indications. In the UK, it's listed for general anxiety. In the US, it's used for fibromyalgia. In Australia, it's kind of second, third line agent for neuropathic pain, but it's one of the most widely prescribed off-label medications around. Well over 50% is prescribed off-label. There's no evidence for effectiveness for low back pain, sciatica, migraine, and various other things that it's prescribed for. And interestingly, Ian Harris, an orthopedic surgeon, does a bit of research stuff these days. He did this systematic review with his colleagues here, looking at the various studies that have been done on pregabalin over time. It's really interesting, and I'm sorry this is a little bit small, but basically broken up into 5-year segments here. And you can see that, the dots on this side, on the right side, favour the pregabalin, and the dots on the left, or as the dots shift to the left, it's more favouring placebo, and crossing of the midline shows no benefit of the drug. So you can see in the first 5 years, tremendous results. the second set of 5 years, things start to shift a bit more to the middle. By the third set of 5 years, there's really no benefit of benefit, and that gets even less so in the last 5 years. So you can see there that little comment from them that our study provides evidence of a decline in the treatment effect of pregabalin relative to placebo over time, was consistent across all doses and indications except for acute hepatic neuralgia, and it was not explained by changes in baseline differences or study characteristics. The treatment effect of pregabalin is smaller than the accepted threshold of minimally clinically important difference, which is really interesting for a drug that's so widely prescribed. The evidence shows it doesn't do anything except cause problems. So something to really think about in terms of prescribing that to patients. And you can see there a lovely study done by Rose Cross and team in Victoria, looking at increasing rates of prescription for pregabalin and increasing ambulance attendances. And you can see that really nice mapping on top of each other as the prescriptions went up. So did the ambulance call-outs related to pregabalin. And again, what she found was the sedatives that were most commonly misused with pregabalin were benzos and pharmaceutical opioids. So how do you wean these things? Well, it's really tricky. I think that weaning benzos and gabapentinoids is probably one of the most thankless tasks. They're pretty easy for people to get elsewhere, but it's still really important to give it a try. And I think being really clear with patients and all that typical expectation setting and things, but exactly what Karen had mentioned before. So making sure that there's a contract, that they only see one doctor, and script check certainly enables you to at least monitor the prescribed access to these medications. So a sole chemist, a staged supply. So for some people, they need to pick it up daily, but twice a week, something like that at the very least. Generally weaning people on a long-acting benzo, so diazepam. Clonazepam can also be useful if you're doing urine drug screens. Clonazepam has no breakdown products, so it'll just show clonazepam only in the urine. So sometimes that can be helpful to differentiate if they're taking anything they shouldn't be. And you can ask them to differentiate the benzos and show you what's in the urine. So again, psychological support is important if people can manage it. Pregabalin, again, likewise with benzos, pretty tricky. So there's good evidence that you can cut people down to 600 milligrams, so max therapeutic dose straight away from whatever dose they've been taking. Even if they've been taking 3 or 4 grams a day, it's safe to bring them down to 600 and then just start a gradual wean from there. I generally encourage drops by 75 milligrams at a time. How quickly you do that, look, I think from a sustainability point of view, if you try and go too fast, people go and get it elsewhere. So it's got to be slow, it's got to be gradual, and it's got to be with other supports in place to help them make those changes. And likewise with the benzos, you try and get them down to 20 milligrams per day relatively quickly, and then a pretty gradual, slow wean from there. It's all about heading in the right direction and making sure that patients are staying on track and not sourcing things from anywhere else. Weaning opioids is really tricky. There's lots of commentary around this. Is a really good article, and I like their commentary here that we know all the problems with opioids, and so the logical thing would be to wean down. But when we wean people on opioids, often those same issues become worse, and people can overdose and die and things like that. And again, here and you can see from that little a table at the bottom, or that little diagram at the bottom, that again, that although people are so tolerant to these opioids and the effect is so small, there does seem to be this kind of salient, limited, small relief from their PTSD, depression, emotional dysregulation, whatever it is. And even the thought of having to cease those medications becomes overwhelming for people. So trying to make reductions can be really challenging. There's still conversations that are important to have with people, but being aware that some people won't be able to do that at all. And I'm a really big proponent of those prescribed opioid dependencies to look at buprenorphine as a harm minimization tool. And there is some thought now, both within Australia and around the world. You can see there the Veterans Affairs Department of Defense guidelines in America have recommended that for the treatment of chronic pain, they suggest buprenorphine rather than full opioid agonists. And I certainly think that's a good way to minimize harm for people. If you're not sure how to do that, really happy for you to refer them to me and have a chat with patients and support them to switch over to BUP and help them to maintain on that. And that, it's clear for people, this is the point study, which is done a while ago now, but looking at people, so these are people with chronic pain who are on opioids for that rationale. And again, almost half of them were taking more than that 90 milligram oral morphine equivalent. About 10% met the criteria for opioid dependence. And again, that kind of aberrant use was associated with the higher doses and mental health issues and things like that, which are really prevalent in this population. So being aware that just because people are prescribed, it doesn't mean they can't run into trouble. In fact, they really can. And this other study done on the same cohort used this PODS tool, the Prescribed Opioid Difficulty Scale, where people self-report how well they think they're coping with their opioids, and almost half of them reported either intermediate or high levels of difficulty assuring that they could take their opioids appropriately. And yet very few of them had actually sought help from an addiction specialist or a drug and alcohol clinic, despite many of them meeting the criteria for opioid use disorder. Very few had had access to medication assisted treatment for it. So really important thing to think about, and DASA is absolutely here to support with those kind of patients. So yeah, think about is MATOD appropriate for this cohort? If people can't wean, if they're really struggling, if they're on polypharmacy with high risk to themselves, MATOD can be life-saving for them. Take-home naloxone is really important. It's really available now on the DASA website. There's a updated list of pharmacies that people can get free access to naloxone, and anyone who's prescribed any kind of regular dose of opioids, I'd really recommend you giving them some of this. It's a great way to start a conversation with people about the longer term risks of opioids, and sometimes can initiate a little bit of motivation to look at something differently. So please have those discussions with people, and very happy for you to again send them to us if they get stuck. Now just next to my thing, yeah, okay. So just before I run through these, so Kevin did ask a couple of questions, and so Kevin's asked about prescribed cannabis from telehealth prescribers. Is there an analgesic effect, or is this largely placebo? Certainly there's been a massive growth in cannabis prescribing, and most of it through telemedicine. So I think we're up to about 150,000 people on prescribed cannabis across Australia now. Interestingly, there's been a bit of a shift. So initially, most of the scripts were under a pain indication. There seems to be a growing rationale for sleep and anxiety. Strikes me as rather strange that someone would take cannabis for anxiety, but those seem to be the increasingly used indications. And you can look this up on the TGA website if you're interested. And pain certainly is still one of the listed common indications as well. Look, there's been lots of studies done, Kevin, and to be honest, the evidence is really poor. There's no really compelling evidence that cannabis is effective at managing pain. That's not really surprising. I think that kind of anecdotally, my experience is that the people that like it the most is probably people who've used cannabis more in an illicit way, and this gives them a illicit access to it, and maybe that's a reasonable thing. I don't know. But look, in terms of if people, again, are looking for that silver bullet to manage their pain, they'll largely be disappointed by the cannabis. It's very expensive, about $300 a month. And the problem, I guess, is that generally they're these one-stop prescribers, so they don't really take into consideration the rest of the person's health needs or even who they are, and they just prescribe the kind of cannabis in a vacuum. So there's lots of risk associated with that, and I think there is an increasing awareness of the dangers associated with this, lots of media attention, and I know the College of GPs has been flagging it as an issue, so we might see some changes to that coming up in the near future, although there is a lot of vested interest in this area as well. So being interesting to see. And then Kevin said, in complex chronic pain addiction presentations, are buprenorphine patches safe, recommended? Yeah, look, I use bupe patches a lot for people. Again, if you're worried more about aberrant use and dependency and things you might put in place, and things like they have to swap the patch at the chemist once a week. So you just give them one at a time. But other than that, Bup's quite safe. Probably the main issue is that the oral morphine equivalent, even of a 40 microgram patch, is only 80 milligrams of morphine. So if you've got people that are using fairly high doses of opioids, then a butte patch won't be any good for them, and you really got to look at Suboxone instead, which is fine. But yeah, if it's lower level use, even if they're not using it aberrantly, if they're just really struggling to wean opioids, I really like bupe as a harm minimization, and I think a patch can be really good. Probably the main issue is that the people that you most want to put on a butte patch are the ones that invariably get skin rashes and things from it, and that can be a bit of a pain. So you've got to then look at sublingual options instead, maybe Subutex or Temgesic or something like that. But for those who it works well, patches can be excellent. They can be really stabilizing for people. So yeah, definitely encourage having a chat about that with patients. In terms of pain resources, so these are some of the ones that I think are really helpful. So the one from the government of New South Wales has a lot of excellent stuff in there, and you can show patients that as well. Lorimer Mosley's got excellent stuff, Adelaide-based pain researcher. So things like Tame the Beast and a book he wrote with Dave Butler called Explain Pain. The Brain Man videos are short but excellent to show people. Also haven't put on here, there's a really good app called the Curable app, which patients can download. I think it first month is free, and then it costs a few bucks a month thereafter, but like a ton of useful resources. There's a free podcast series as well. So that's a really excellent thing to put patients onto as well. I didn't mention before, but will now. So apart from the Addis phone number or phone line, the other SA government tool that's really useful is this Know Your Options website. So it's particularly for substance use, alcohol and other things. So people can log on here, and they can also, I think perhaps the thing I find most useful in here is people can punch in their postcode, and then it'll spit out a list of resources that are geographically located for the person to access. So I think that's super helpful for people. So yeah, really good one to refer patients through, and you can look at bits and pieces on there and help them with that as well. So in terms of DASA, so we're pretty broad. We cover the state. So we have clinics here throughout Adelaide. So we've got one in Elizabeth, one in McGill, and one down at Morphett Vale. We've got our inpatient unit at Glenside, but then we've also got nursing staff throughout most of the state as well. So wherever you are, you should be able to link with us, and we provide telehealth services to clients regionally as well. We try and be as available as we can to as many people as possible. We offer a service through the hospitals as well, so you might occasionally get a call from our team at the hospital if someone's been admitted to. We have a specific support for First Nations people and homeless people, and again, the telephone stuff that I mentioned. We've also got a residential rehab called the Woolshed up in the Adelaide Hills. Excellent support and long admissions, so 6 to 12 months. But it's pretty small. So unfortunately, there is a decent waiting list for it, but a really great thing for people who are open to, putting aside that amount of time. New Roads, which is run by Uniting Communities, they've got a really excellent resi rehab program as well, and the waiting list is a bit shorter because they've got a few more facilities. So that's another decent one. There's a bunch of others around. Back on Track is a relatively newish one with a more of a Indigenous focus, but also non-Aboriginal people can go there as well. And that's in the city, and they're about to open, I think, 20 new beds. So they'll be around. And then there's Tumberland Farm, Auburn Place, some of these for younger people as well. So Woolshed and New Roads are the main ones, but there is other options available for people too. The support groups I mentioned, AA and Smart Recovery, so those are both really good options. Then there's one-on-one counselling. So these groups tend to shift and change around, and funding comes and goes. But again, New Roads is one of the bigger ones. There's Life Without Barriers, there's Centre Care, which are on Auburn Place, Mission Australia, Sonda, and there's some others around as well. Always the Offenders Aid and Rehabilitation Service has got some support money at the moment too. And then the Family Drug Support, which I mentioned earlier. The DACUS number again. So for you guys, if you want support, you can always send referrals through. But if you want some kind of real-time advice, call through and we'll endeavour to get in touch with you as soon as possible and provide some support over the phone. I'm just going to finish with this. I really like Gabor Mate. He's a Canadian physician that's done a lot of work in substance use. He's written a couple, well, quite a few excellent books, but he's got one called The Myth of Normal and another one called In the Realm of Hungry Ghosts, which is specifically looking at substance use things. This is a quote from The Myth of Normal, that it's not enough to feel bad for people caught in the coils of addiction without seeking to understand what pain in their lives they've been driven to escape and how that wound was sustained. Absent a clear view of the context, one is left at best harbouring inert good wishes and engaged in a well-meant but ultimately ineffective interventions. We see this limitation in the woefully inadequate addiction treatment approaches currently in vogue. So we can do a lot to help people, but we've got to be really thoughtful about how we do that. We've got to understand who the person is in front of us. And that involves kind of looking behind some of the behaviors and looking behind some of the stuff that can look pretty ugly, and seeking to understand who they are and where they've come from. And I think if you can do that and you can connect with patients, you can make really significant, or support people to help make really significant changes, and it can be an extremely rewarding part of your work. And we're always here at DASA to support you to do that. We love GPs who are willing to invest and do this, because there's a lot of it around and we can't do it all. And we're happy to support you wherever we can. We also have a GP training day, which is typically on around June. And if you want to come along to that, you're very much welcome to as well. Generally see Kevin and others there. So very welcome. And yeah, we really like the GPs who are involved, and things like Maytide and things. If you want to get involved in that, we've got programs to support you around that as well. So feel free to get in touch. Thanks for giving up some of your evening tonight. And if anyone has any kind of final questions or anything, I'm happy to try and answer those before we close up.